And the idea that we're trying to achieve is the same with dentistry, basically, and really getting into like, why are people getting gum disease? Why are people getting decay, constantly? Why are they not responding to treatments properly? And getting really deep into it. So, what is the future of healthcare? And I think that was we didn't even mean to, but that stemmed very well with what Joe just said. And the idea is that it's kind of quantitative and personalized medicine. So it's this idea that we're all tracking our data, we're all trying to improve our health, and usually at home now, we're trying to actually do most of this ourselves and understand more about our health as well. So you have to meet the self-optimizing generation. And this is kind of probably a lot of you guys in this room, without stereotyping, because you guys are very open to the idea of functional dentistry, so you most likely are doing a lot of this. How many of you are wearing a wearable or tracking something about your sleep or your data? Anyone? Show of hands? Yeah, all right, we've got quite a few people here, same here. So a lot of us here like to understand how we sleep, how we're exercising, our blood oxygen levels. And on top of that, we also like to change our diets. A lot of us are altering our diets to improve how we feel and our nutrition as well. A lot of people are now going out for yoga and Pilates as they're going out on a Saturday night as opposed to drinking. It's not as cool to drink anymore. It's not as cool to smoke. So we're really seeing a new generation where they're really, really prioritizing their health, and they're actually willing to spend a lot of money on preventing those diseases. To the point where actually there's been a lot of research done, and a lot of patients think that it's better to take care of their own health than to go to a doctor. And this was done in 2021, so this was really due to COVID. A lot of people thought, okay, I don't have access to my doctor anymore. And then after that, I'm not sure if any of you have ever tried to book an appointment with your GP on the NHS, but it's a faff, like it's really difficult. So if you can avoid doing that and taking care of your own health and understanding more about it, then most people are willing to do that. On top of that, more patients would prefer to avoid problems by leading a healthier lifestyle. So we're seeing a lot more prevention coming in now too. So my next question is, what is the future of dentistry? And the answer is quantitative and personalized dentistry. So what does that look like? Personalized dentistry, a lot of people will say, this is what I think dentistry at the moment is for a lot of people. It's just, you need to floss more, you're not flossing. You should eat less sugar, or you have gum disease because you don't brush your teeth. It's your fault that you have gum disease, and it's nothing to do with me. Let's watch this lesion and maybe fill it this time. It's my favorite one, where and then 6 months later, we're like, so sorry, that lesion now needs to be filled. Or you should just change your toothbrush. Something's just not working, so just change it, basically. No, my answer to functional dentistry is the idea that we actually start to recommend some nutrition. Obviously, not beyond our scope, but there are definitely things that we have been taught at university that we understand and we can start recommending to our patients. The idea of doing maybe blood testing or sending out patients to get their bloods tested. So if you have a patient who has severe periodontal disease and you know that they're super inflammatory, maybe there are other things going on. Or if your patient's constantly having ulcers or anything like that, thinking about actually checking their vitamin levels and making sure that they're not low on any of those vitamins. The idea of, I think, prescribing oral hygiene to your patients. So giving them use this toothpaste, use this mouthwash, use this toothbrush, even take these supplements, and giving it to that patient. You can do that in any environment. Even in an NHS environment, you can have like a pad and literally just scribble or tick the ones that you want to give that patient. And just the act of giving them a piece of paper gives that responsibility to that patient to then go ahead and buy those things. I personally put links in my treatment plans. So I'll link everything. They just have to click and buy it, and it's much easier for them. The use of artificial intelligence. So we're now seeing a lot more artificial intelligence with our x-rays. We're able to actually quantitatively diagnose the amount of decay, how deep the decay is in the enamel, whether or not we need to interfere. And then on top of that, actually treating that before it becomes a cavity. So there are a lot more things. So there's something called cure, don't repair. I don't know if you guys have heard of that before, but it basically is able to reverse early decay interproximally. So it's kind of like, if you guys have heard of proximal icon, it's kind of similar in the case selection, but it actually uses, I'm going to be really bad at describing this, but it basically takes the calcium and the phosphates from your saliva and helps to remineralize the decay. And actually radiographically, after 6 months to a year, a lot of these patients' decay has been actually completely reversed. So definitely search that. Cure, don't repair is really cool. Collaborating with other healthcare professionals. So if you have a patient actually saying you should go see your doctor or you should see a gastroenterologist, you've got lots of erosion and you definitely have some acid reflux, and actually referring to that, not just saying you should go and see a gut specialist. You should actually, in my opinion, write a referral letter to that gastroenterologist, and they will definitely actually, I've seen that gastroenterologist will start to refer patients back to you because they're like, oh, this dentist is quite switched on. She's thinking in a different way. And I get a lot of referrals just by actually just writing a letter and just saying who I am and this is what I think. And usually if I have data, so if I've got their oral microbiome results, they're like, oh, I actually understand this now. These are numbers that I can understand. Detecting and treating airway and breathing issues. So I touched on that earlier this morning, but I think that's a huge area that's going to grow massively in the next couple of years. And already there's a lot more on myofunctional therapy. It's the idea that we, as dental professionals, can actually pick up particularly young children who are having these problems and avoid them having issues in the future. So we now actually understand that mouth breathers, when they're older, have a higher risk of ADHD, of fatigue, of having chronic inflammatory conditions. And the exact mechanisms are still not fully understood, but if you could stop that patient from mouth breathing when they're a child, it's much easier than when they're an adult. And I'm sure Ariane will be able to say more about that if you find her at the break. And then obviously, oral microbiome testing. So why have we found this massive split between medicine and dentistry? So in 490 BC, Hippocrates, the father of medicine, he strongly believed that teeth were an important part of medicine, to the point where actually there was a lot of work that he did where he said that he treated a patient's rheumatoid arthritis. At the time, he was not doing gum treatments, but by pulling a tooth out. And so you can see again that he actually really thought that all of it should be combined. But then unfortunately what happened was the evolution of barber surgeons. And basically you could get your hair cut and your tooth pulled out at the same time. This really was not a great time for dentistry. And so, they were like same tools, same stuff. And so that's when dentistry started to the mouth got kind of slightly separated from the rest of the body. And then Fauchard in 1679, he said, no, actually dentistry is a real thing. It shouldn't be done by a hairdresser or a barber. And there should be proper formal training for that. So he wrote the first ever book on dentistry, and he believed that dentistry should be a part of medicine. But even with that, the University of Pennsylvania in 1765 opened the first school of medicine ever. And dentistry, unfortunately, was not included in the syllabus. So they learned about every single organ, everything else in the body, except for this part. And so in 1840, the Baltimore College of Dentistry was like, well, I'm going to show you guys, we're going to open our own college, and we're only going to do the mouth and the teeth. And so that's where the first dental school ever opened. And that's where we see this kind of separation. And in my opinion, now, maybe in 2024, I don't know, we can have whole body health. It's the idea of integrating medicine and dentistry. And a lot of the work I do is actually often not educating dental professionals. It's often educating nutritionists, functional medicine practitioners, doctors, so that they actually understand how important it is for the mouth to be factored into their treatment plans. If they can start referring patients to us, then it'll be much easier for us to refer patients to them. And one of the biggest issues, in my opinion, is that doctors don't understand what dentists are doing. We understand what they do most of the time, but they don't understand what we're doing. Because, to be honest with you, we have all these words, we're like, oh, you've got, grade 4, stage 2, A, grade C, la, 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 all of these things that when no one knows what we're saying other than us. And if we're able to translate that into quantitative numbers, if I was able to tell a doctor, okay, look, I have a patient, has really high levels of these really pathogenic bacteria. You can see red, red, red. These are all terrible. Really high levels of inflammatory markers. And they have genetic mutations which increase their risk of inflammation. Would you mind treating this patient and just checking everything else? They can understand that. I don't even have to say periodontal disease. I don't even have to say decay. They just understand bacterial infection, inflammation, and then they can get going with whatever they need to do. So why should medicine and dentistry be integrated? So first of all, we as dental professionals see patients much more regularly than doctors do. So ideally, your patient should be coming every 4 to 6 months for their checkup or their hygiene. So actually, it is a very great time for us to maybe check someone's blood pressure, check their blood glucose levels, or maybe even if you want, integrate blood testing in there and actually picking up these problems early before they actually become an issue. So if you were able to pick up a patient at pre-diabetic and actually then recommend that they go and see someone for that, that's saving that person a lifetime of medication, of being diabetic and struggling with that. And we are at a prime opportunity to do that. And actually in America, they're already doing that. There are so many dental practices which are integrating dental with medical. Or Henry Schein, their biggest thing at the moment is dental medical integration. And they're trying to make sure that dental practices start to do just early, we're not taking over medicine, but just early, small, simple, cheap things that we can do that will actually add value to our treatments, but also to our patients' full body health as well. As we said, the oral and gut microbiome are very connected, and we can actually start to flag up issues much easier, and it's much more convenient for a patient to come to us usually than to go and book an appointment with their doctor as well. So how can we actually do this? What are the options that we have to making dentistry more personalized? So this is currently what we're doing for diagnosing and managing periodontal disease. So if we see bleeding on probe, we basically poke the gum really hard, and then we wait, and we see if there's any blood coming out of the gum. And if there is, they're like, oh, there's a lot of inflammation going on. It's completely subjective, depends on how hard we're poking, how blunt your probe is, and how long you wait until the bleeding starts. And then sometimes, I remember in my early days, I would poke, and then I'll be like, oh, it started bleeding like 2 minutes later, and then I have to go back in and put it on my bleeding on probing chart. So to me, that's completely irrelevant. It doesn't really make sense what's happening in that point. Also, what we were talking about earlier, a lot of patients who have things like your endometriosis or other inflammatory conditions are going to have bleeding gums. So do we understand if that inflammation is coming from the mouth or from the rest of the body? And so again, it's very difficult to really be able to track anything with that. Active periodontal disease, we get our probe, we see how far it goes down into the pocket, we measure it, and then we make a 6-point pocket chart or a BPE. Quite subjective. False pocketing, what happens if you have hypertrophic gums? What happens if there's quite a heavy-handed dentist who's really going down there, or someone who's a bit scared? To me, it again is quite inconclusive a lot of the time. Bone loss, so for historic periodontal disease, the only way we really know if a patient has a history of gum disease is we look at their x-rays and we're like, oh, you have 20% bone loss. You must have had gum disease at some point in your life. I don't know when, I don't know how, I don't know where, but it happened at some point. So again, quite subjective. You don't really know if it's still active sometimes, or if it's going to come back, or why it happened, nothing. You can just kind of note that something happened, basically. Periodontal abscess, we just poke, and then if there's something yellow coming out, we're like, there's pus. You have no idea often what the cause of that is, what bacteria is in there. You don't often know if it's endo or periodontal, or if it's a perioendo lesion. So again, quite difficult. And this, for me, is the most important, is risk of periodontal disease. I had a patient the other day, adopted. She says that she has no idea if she has a family history of gum disease. She was Asian, and she was like, I think I might have a higher risk of gum disease. She was like, I brush my teeth 6 times a day. I've never smoked in my life, and she did have gum disease. And for her, she doesn't know her genetics. She doesn't know her risk of gum disease or any of those types of things. So actually, all we do at the moment is we say, oh, did your parents lose their teeth early when they were younger? Or do you know if there's a history of gum disease or decay in your family? And you can't always get the right answer. And particularly because we're now living until much older, does that, we still can't really understand the family history in that. So it's not the most trustworthy. So this is my idea of what we can do. So if we have a patient who has inflammation, we can actually check their inflammatory markers, and we'll show you some options for that later. If someone has active periodontal disease, then we can actually test their saliva to see how much collagen is being broken down in real time. And again, I'll show you the test options for that as well. That is quantitative. You get a number for the activity of the gum disease. It's something you can retest, and you can see it going down, which shows that the gum disease is getting better. And it's very precise compared to what we currently are doing, in my opinion. Historic periodontal disease, so you can do a microbiome test. You can actually still see bacteria. There are some bacteria which are more associated with chronic periodontal disease, and some which are more for active. And again, obviously still bone levels, but you can start measuring that with artificial intelligence. So I use Pearl, and you're actually able to quantitatively measure the bone level loss and say, okay, you've lost 10% in the last 5 years when they compare the 2 x-rays to each other. Risk of periodontal disease, so you can do genetic testing, so you can look for base pair mutations in your patient's saliva, and that way, I mean, it's pretty accurate. Okay, so this is the idea, is that you can screen and diagnose someone in your dental chair, be that with medical stuff, so you can start to do even a simple blood pressure check, maybe a blood glucose test. So we do blood glucose tests for every patient who has periodontal disease. We check their HbA1c and we check their vitamin D levels. 9 times out of 10, they have low vitamin D levels. Very rarely have I ever seen anyone with normal vitamin D levels in the UK. And HbA1c, once in a while we get it, and when we do get those patients, it's a huge lifesaver. It's a really big change for them. Then you're obviously doing your dental treatment and your prevention, and then you can start to personalize their oral hygiene, personalize their dental treatment, and even personalize their nutrition, their diet, and their supplementation. And once you've done that, all you need to do is just monitor and just make sure that they continue what they're doing. So how can we check for all of these bacteria and all of these things that I was telling you about? And this is where I guess my name, Saliva Queen, came along. And this is because saliva, I think, is definitely the future of diagnostics for dentistry and even for general health and medical as well. So we're going to go through a few different options for saliva tests. And these are the things that you can start to actually look at in your saliva. So before we start getting into it, I thought it would be interesting for you guys to see that obviously we're here talking about teeth and dentistry, but actually saliva is already being used for diagnostics in other situations. So they're actually finding, so there's a simple saliva test that can check for your cardiovascular disease. This test, the OraQuick HIV self-test, quite strong. It says it's got 99.6% accuracy for testing HIV. It's a pregnancy test that you can get from the pharmacy and you just spit into it. They're also looking for oral cancer and even colorectal cancer as well, just through saliva testing as well. And obviously the beauty of saliva is that it's so easy to collect, and so it's not painful, and it's much cheaper as well most of the time. This is where I think it gets really exciting. So with prostate cancer, they found that a saliva test is more efficient and more precise at diagnosing prostate cancer than standard blood tests were. So this is where saliva is now superseding the other diagnostic mediums that we have. And on top of that, I thought this was something that maybe some of you are already aware of. So you already do check a lot of your stress and your your stress levels, your cortisol, etc., through saliva. And this has kind of been around for quite a long time. And for some reason, everyone thinks that's normal. But when I start talking about saliva for periodontal disease, they're like, wow. So this is something that maybe some of you have already actually done before. So number one that we can do with saliva is looking for bacteria. So you can analyze your saliva for good and bad bacteria or pathogenic bacteria, which are associated with your dental diseases. And I think this is really important because you can actually diagnose the dental disease properly. You can help monitor the treatment, so you can do before and afters and see whether things are improving. I think the most important thing is it's extremely motivating to the patient because you are actually educating the patient and showing them what's going on. They understand it, and they are 100% more likely to take into consideration your oral hygiene recommendations and actually do it at home because they get it, you know. And obviously, you can also evaluate treatment outcomes. So I'm starting to sometimes compare different products that I'm using, and I'm like, ooh, this product was better than that product, or even, I don't know how harsh you guys are, but you can compare different clinicians if you wanted to. But you can start to compare different things and see what's doing well, what's not doing so well. And this is what I was saying about treatment outcome. So you can see here that in 3 different time stamps, we've done oral microbiome tests, and the red was before, green is after. If you show that to a patient, you're like, wow, look at what we've done and how we've balanced everything. I mean, they're a patient for life, in my opinion, but also they actually truly understand that, and they're motivated and they feel like they've done something good. They have green now, they're happy, you know? So are all of these dogs the same? No. Probably like, wait, why did she just go from saliva to dogs? So same species, different breed. So this is really important because a lot of bacteria, as you'll see here, will have the same species, but will have lots of different strains or breeds of that same bacteria. And so this is really important because a lot of the current oral microbiome tests that are on the market are kind of quite like surface level. So they just look at just the bacteria present in the mouth. They can't really differentiate between if you have a very pathogenic strain of that bacteria or if you have quite a good strain of that bacteria in your mouth. And so it actually was starting to be a little bit confusing because you didn't know, you get these results and be like, oh, high levels of Porphyromonas gingivalis. And you're like, don't know if it's doing a good or a bad thing in that person's mouth, but generally it's quite bad, so I'm going to assume it's bad. Like there wasn't very much there. So you can see here, so we're looking at, I'm going to split it up into the bacteria associated with decay and bacteria associated with gum disease. So first off, decay. So these are your three big baddies, your strep mutans, your lactobacillus casei, and your strep faecalis. And we know that these are causative of decay because in 1960, Paul Keyes, he got some germ-free rats, and they had no decay. And he injected them with strep mutans and also with sucrose, and he found that those rats then developed decay. But when those rats were just injected with strep mutans and no sucrose, they didn't get decay. And when those germ-free rats were just injected with sucrose and no strep mutans, they also didn't get decay. So you need your strep mutans and you need some sucrose together to cause that decay. And then we go on to our periodontal disease. So I would say the biggest, baddest, worst one, I'm sure you guys have learned it at university. I'm not going to pronounce it for you. I'm going to call it AA. So AA is probably when we look at the pyramid, it's the tip of the pyramid. It's the worst one that you can have. It's gram-negative, it's anaerobic, so it hates oxygen. And that makes it actually easier kind of to kill because you know that you just need to throw loads of oxygen in there to kill it, essentially. It's associated with very aggressive periodontal disease, and particularly in younger patients. And on top of that, this is what I was saying about the kind of the breeds and the strains. So we can all have AA, but some of us will have really, really aggressive strains of AA, and that AA can be releasing virulence factors. So these virulence factors can be things like leukotoxins, they can be stimulating bone resorption, and other patients will not have. They'll have the AA and none of those factors. On top of that, there's also something called the JP2 clone. And the JP2 clone is hyperleukotoxic, so it's even more aggressive than the normal virulence factors. So it's releasing loads and loads and loads of leukotoxins, which are breaking down the tissues. It produces 20-fold compared to your normal AA. So it's really, really high. It's enhanced destruction of immune cells. It increases your tissue damage. And you're 20 times more likely to have periodontal disease if you have the JP2 clone. I'm yet to find someone who has JP2 clone. So if anyone has like an early perio person, then just let me know. I'm trying to find them. But it's rare, but when it does happen, these are the types of patients who are losing all their teeth before they're 18 or 20 years old. It's very, very aggressive. It's mainly in North African descent or Mediterranean as well. Next up, again, I would say the second baddest is your Porphyromonas gingivalis. And this really is a very inflammatory bacteria, so it promotes inflammation, tissue destruction. It's very good at evading the immune system. So it kind of hides behind the immune system and it doesn't get killed very easily. And it's acid resistant, so it can travel to the gut really easily. So P. gingivalis, I would say, in my opinion, is one that really links them out to the rest of the body. This is the one that we're seeing the associations with things like your cardiovascular disease, your adverse pregnancy outcomes, your Alzheimer's disease as well. So this is one, because it's acid resistant, it can travel around, it's very inflammatory, and it also it can be very, very destructive. Now, on top of that, P. gingivalis has a lot of virulence factors. So again, going back to that strain and the breed, we can all have P. gingivalis in our mouths, but some of us will have really, really high levels of virulence factors. And these virulence factors can enhance the host tissue destruction, collagen destruction, they can scavenge heme, and they can actually, one of them, the fimbriae, it's like little filaments that come out of the bacteria, and it basically means that it can like stick onto tissue better and colonize it even better. So a lot of patients, now that we're doing the test, are coming up with really high levels of these as well. So again, this is these virulence factors and the gingipanes, if you rewind back to the Alzheimer's conversation in the morning, this is what's also very strongly connected. So they're finding these virulence factors really high in patients who are suffering from Alzheimer's as well. So this is where also the test hopefully is going down, is that we can start to see, I'm starting to see patients who have really high levels of virulence factors. Maybe they have the APO gene mutation, and these are very high risk patients for Alzheimer's. And you can actually start to get rid of the P. gingivalis and reducing that risk. Because with something with Alzheimer's, it's multifactorial. There's a lot of things that you can't change. You can't change your genetics. If you have the APO mutation, that's, you can't do much about it. But what you can do is make sure that you have as low levels of Porphyromonas gingivalis as possible. And if it's a big puzzle, that's at least one piece of the puzzle that you've kind of fixed or sorted. Tannerella forsythia. So this is, again, key pathogen, key bacteria, very strong inflammatory response, lots of tissue and bone destruction, very associated with periodontal disease, and it forms very resilient biofilms, which are quite hard to remove and to clear. By the way, guys, you're getting recordings of this afterwards because I feel like I'm probably going to overwhelm you with a lot of bacteria today. So just to warn you all. Treponema denticola, and this is also gum inflammation, tissue destruction, and bone loss. So they're all kind of now doing the same thing. I would say if you had to take your top 3 or 4, it's your AA, your P. gingivalis, and your F. nucleatum, which is coming up now. So Fusobacterium nucleatum, another one which is very strongly connected to the rest of the body as well. So it promotes dental plaque formation and biofilm. It triggers inflammation and destruction. And again, it can evade immune system. And there's very, very strong associations now with the colorectal cancer. So that study I showed you guys with over 50% of colorectal cancers having Fusobacterium nucleatum. It's also very associated with infertility and pregnancy issues. So this was the bacteria that was being found in the placentas of patients who were delivering preterm births or low birth weight as well. And also more recently, breast cancer. I didn't know this, but apparently your breasts also have a microbiome. And what they're now finding is that patients who have breast cancer have Fusobacterium nucleatum in their breasts compared to patients who do not have breast cancer as well. So again, this, I would say F. nucleatum, it seems, it's early days, but it seems to be very, very carcinogenic. It definitely is exacerbating tumor growth because it seems to be all in a lot of cancers, basically. Prevotella intermedia, this is your inflammatory one. So this is, for me, when I see high levels of Prevotella intermedia, I'm like, this person's pretty inflammatory. They've got a lot of inflammation going on. It's very associated with systemic inflammation and also your gum inflammation as well. And then this is just for your general inflammation. These are the two which I would say are quite strongly associated. And this is kind of like my cheat sheets, by the way. So a lot of this is stuff I've learned, but also I'm trying to make it easier for you guys to understand a little bit. Probably a lot of you know this. I know we have an endodontist somewhere here. There we go, endodontist right there. So epicalis, you probably know a lot about that one. So this is very strongly associated with failed root canals and with the persistent endodontic infections and periapical infections as well. So actually I did a oral microbiome test on a patient and she had super high levels of epicalis, and I hadn't done like a OPG, I hadn't checked all of her teeth, like the roots of them. After seeing that, I was like, that looks a bit dodgy. And then we did an OPG, and it turns out that she had 2 massive periapical infections as well.
Can I interject there?
Yeah.
Obviously, for my because I think one of the really interesting things, as you know, is that, I mean, it'd be interesting to see what your standpoint is. Bad root canals can have a massive impact on the immune system.
Yeah.
Dentists coming out saying every root canal that was ever done should be pulled out. So I think there's sort of kind of a happy medium, and obviously with endodontists.
Oh.
So what's your stance on, if you take, for example, do the test, take the x-rays, there's that root canals that have been asymptomatic, but then you're seeing elevated levels. I mean, what would be your first, like to get the root canals redone or to have the teeth pulled out?
So this is where, it's a very good question. I would say, I call myself a functional dentist because I do not call myself a biological dentist. Biological dentists are very, very much, every root canal should be taken out. Every titanium implant taken out. They're quite, I'm sorry if any of you believe in this, they're quite aggressive in my opinion. And then you have the very, very conventional dentist who is still placing a lot of amalgams, and they're not really thinking about other things. They're doing a root canal in 10 minutes. They're using chlorhexidine instead of using bleach. And they're doing harm for sure. And I think that the biological dentists have kind of been fear-mongering a lot of patients and people to think that all root canals are bad. And in my personal opinion, they're not all bad. Only badly done root canals are bad. If they've been done well and by a root canal specialist, and in a very, you guys have your own ways of doing things, very aseptic, you make sure you're using the right antimicrobials, you're using a rubber dam, 3D scans, you're not missing any of the canals, then there's no issue with it. And even now, so most of my patients will come and they'll be like, should I get all of my root canals taken out? I'm like, you have to balance the harm of taking out all of those teeth and then placing something foreign into your body like an implant and then having to take care of that versus actually sometimes these root canals are completely fine. For what I do, I will take a CBCT of most root canals just to triple check and make sure that there's no periapical infection, because often on a 2-dimensional x-ray you can't see it. So I always do check that, and I do recommend that patients get that rechecked every 2 years or so. If they have really high levels of E. faecalis and I've done the CBCT and there's nothing, then to be honest with you, I wouldn't touch those root canals. I don't think it's worth it yet, but I would definitely have them at high risk and just kind of keep on monitoring it. Again, this is my own personal opinion. I don't think so. I think a lot of the research has been quite poorly performed. They're pulling out a lot of statistics and not really showing the full picture of these. There was that film, The Root Cause on Netflix, got pulled by, I think, within like 2 days. And the issue is that they're not able to differentiate between causation and correlation. And so a lot of the time they're like, oh, did you know that, 80% of patients who have breast cancer have a root canal in them? But then when you actually look at our whole population, 80% of our whole population also have root canals. Most of us, particularly over the age of 30, have a root canal. So it's very difficult to differentiate that. If you really, really want to be like the gold standard perfect, in my opinion, you would do your oral microbiome test, you would do your CBCT, and you could also check their inflammatory markers as well. So I had a patient quite recently, worked with Jo actually on, and she was going through cancer treatment, and she had really high levels of CRP, and she did have a failed root canal, which was not doing her any good. And once we took the root canal out, her CRP levels went down. So I'm not saying that there's no connection, but that was a bad root canal that was clearly infected and had a lot of problems with it. Yes? I totally agree. No, and I totally agree. And also the way that root canals are being performed now is very different to how they were being performed 30, 40 years ago. So more research needs to be coming out, and you need to be shouting it from the rooftops, please. So moving on to inflammatory markers, speaking about CRP. So you can also test for inflammatory markers as well. I would be a little bit cautious with this because when you're testing from the saliva, it is difficult to differentiate between inflammation specifically in the mouth and in the rest of the body. But there are companies, so if you scan that QR code, there's a company that does offer inflammatory marker testing. But again, I don't do it personally myself because I find it a little bit difficult. This is one that we do at our clinic. It's called AMMP8. So AMMP8 stands for Activated Matrix Metalloproteinase 8. It is an enzyme, and is an enzyme that's responsible for collagen degradation and breakdown. So we have lots of different types of collagen in our bodies, and one collagen in particular is what makes up our gums, essentially. So if you have really high levels of AMMP8, that means basically that you have very high levels of collagen destruction, and therefore you have gum disease. I found this to be extremely accurate, and so we do this on pretty much most of our patients who have periodontal disease. 100% I'll do it, and I'm trying to make it more of a screening tool as well. So the issue with gum disease is by the time we can clinically see it in the mouth, it's too late, destruction's already occurred. But we actually understand that from a biomolecular level, it's happening up to 1 year prior to that destruction occurring. And so you can test through the saliva that collagen breakdown before it's actually caused bone loss and destruction, and then reduce it and bring it back down. What's also really beautiful about this is that you can retest constantly. So if I have a perio patient, I'm doing their full mouth disinfection, I'm doing all of those things, I retest them after 3 months. Pretty much all the time it will reduce. So I'll go from 100 down to absent. And absent basically means that everything is perfectly stable. And that patient, you can then keep on, if they're coming every 3 months for their recalls, keep on retesting them and making sure that they always stay less than 10 or they're absent. So it will tell you something is happening. It will not tell you what is happening. So most of the time it will be periodontal disease. Once in a while, it can be that the body's under a lot of stress because it's the same inflammatory pathways, it's the same sort of issue. But like I said, you won't know what is causing that elevated collagen breakdown. So this is a nice, easy screening tool. It's cheap, and it's you can do point of care. So it takes about 10-15 minutes. So if you guys need more information on this, let me know. And then also genetic testing as well. So we're going to go through a few base pair mutations. So the first one is your IL-32 gene, and a variation in this gene has been associated with an increased risk of caries, particularly when strep mutans is present. Next up, you've got your GALK2 gene, and a variant in this is associated with higher risk of caries, particularly in children. And I was speaking to someone here who's a pediatric dentist somewhere, and so this could be down the line something where you can start to that you can start to actually test and see that these patients, children, are at very high risks of decay, and actually stop it before they have lots of decay. So it could be that you're using a more remineralizing and strengthening toothpaste. You're changing, maybe putting probiotics, those types of things. Your TASIR2, so this is one of your sweet tooth genes, is what I call it. So a variant in this gene has been associated with a decrease in sweet taste perception. So I have this genetic mutation, unfortunately. So what that means is that I need like 3 bars of chocolate to feel satiated, whereas maybe the average person only needs 1 bar of chocolate. So I like a lot of sugar, and my body wants a lot of sugar. Then the next one's your GLUT2 gene, and this also is decreased sugar sensitivity. And also, again, I have this mutation. You'll see me outside just like eating all the chocolate. If I'm stressed, then I'm more likely to run to a bar of chocolate than to go and have some alcohol or go gamble. Or, everyone has the thing that they do when they're stressed. I'm not going to lie, mine is chocolate. I ate chocolate last night before this conference. So that is my one. And a lot of people have this as well. The IL-1, and then we're going to periodontal disease. IL-1A gene, so this is associated with an increased risk of bacteria colonizing around the gums, and therefore an increased risk of periodontal disease. Your IL-1B gene, and a variation in this gene has been associated with an increased risk of just gum inflammation, so just gingivitis as well. And part of this sometimes, by the way, you can't change someone's their genetic mutations, but what I found is it sometimes is really rewarding for the patient. Like these patients who are constantly struggling, and they're like, oh, why do I keep on having decay? And I try so hard. And it's not a cop-out, but you can be like, actually, you have all these mutations, so you are at a higher risk of decay. So you need to be, 120% compared to the average person. The TNF gene, this is my favorite gene. A variation in this gene has been associated with higher levels of inflammatory markers, and it correlates to a 2 to 3-fold increase in periodontal disease. So the patients I've seen who have the TNF gene are those patients who are getting kind of really rapid periodontal disease after the age of 40s. It's quite resistant to treatment. A lot of the time, by the time they've come to me, they've had 3-4 different rounds of periodontal treatment elsewhere. They brush well, they take care of their health, and they're really, really frustrated and upset. So this one is quite an important one. And then the IL-6 gene, which it actually lowers your levels of your interleukin. So there are some good genes as well that can actually improve your inflammation too. So should we only care about bacteria? And this is why I've created this, because it's not just about bacteria, it's about how your body responds to that bacteria. So I thought I'd take you to a little case example. And so we've got Jennifer and Ethan, and this was just part of the stuff that we were doing for NASA. And so you've got Jennifer. She has a checkup twice a year. She has a few fillings and crowns. She has a hygiene 3 times a year. She's like your ideal patient. She's great. She's a dry mouth, but she brushes twice a day. She's a bit stressed out. She's about to go to space and stuff, so she's a little bit stressed. Ethan, he has a checkup and hygiene once a year, brushes once a day at a push, smokes until he's 18 years old. Yeah, and he only comes for his checkup and hygiene because it's paid, so he's not really that into his oral health as well. So which one of these people is going to have the emergency? Anyone? Yeah, I feel like I set you up for that one. It's Jennifer. And the reason that Jennifer has it is because she actually, when we did oral microbiome testing, she has high levels of bad bacteria. She has high levels of collagen breakdown. So remember the AMMP8 testing I was telling you about, through the roof. She has a very dry mouth, so talking about that xerostomia, the lack of saliva providing food and proteins to the bacteria. She has fillings actually very close to their nerves, and in zero gravity conditions, all of that's kind of elevated and you can get problems quite quickly. And also she has genetic mutations which predispose her to inflammation, inflammation. So what is the cause of periodontal disease? Bacteria, your host response, and your risk factors. And I'll move that. Meet Oralis One. So this has been my little baby that has taken a year to develop and to grow. And to explain it better is me again, but in a different format. Hi, my name is Dr. Victoria Sampson, and I'm a dentist and the founder of THS Labs. Did you know that the mouth is the first entry point for bacteria into the rest of your body? Every time you breathe, you eat, you drink, or even you kiss, you're introducing new bacteria into your body. As a population, we spend millions on improving our gut health. We take gut microbiome tests, probiotics, we change our diet, but many people actually don't appreciate how important their oral microbiome is and how to improve it. The oral microbiome is the gateway to the rest of the body, and what some people actually say is an extension of the gut microbiome. Many also don't realize that common oral diseases like gum disease or decay or bad breath can be caused by an imbalanced oral microbiome. The growing body of evidence also links an imbalanced oral microbiome with general diseases. 70% increased chance of Alzheimer's, 51% higher chance of diabetes, 2.85 times more likely to have erectile dysfunction, an increased chance of infertility, rheumatoid arthritis, and the list goes on. Having done microbiome testing for years, I realized to fully treat a patient's disease, I had to understand what bacteria was causing the disease in the first place. Presenting Oralis One, a salivary diagnostic tool that can be done in the comfort of your own home or at your dentist's practice. Just using a few drops of saliva, we can get a deep dive into your oral health and also your general health. Oralis One tests for bacteria, genetic mutations, and other biomarkers to give you a full insight into your oral microbiome. This is the first test on the market to not only look at the bacteria in your microbiome, but also how your body is responding to certain bacteria. Our state-of-the-art technology ensures accurate and reliable results, which are delivered to your online dashboard for you to see. The test also creates personalized treatment plans for you and your dentist to see. These treatment plans have been created by our team of nutritionists, functional medicine practitioners, and doctors to create a personalized and holistic approach to your oral care. Take control of your health with Oralis One. Early detection means early prevention and better personalized care. Oralis One, your health in a drop of saliva. I hate the catching bit. Makes me cringe every time. So there are lots of oral microbiome tests on the market, and the point of this conference is not for me to sit and sell it at all. It's just that I don't think anyone should be doing oral microbiome testing unless you fully understand, and that's why I went through every single bacteria, all the different genetic mutations. Obviously, I'm a bit biased. This is the one that we've created, and it's because I've been doing it so long that I know the faults of others. But please come to me later, and I can tell you all the other options for other oral microbiome tests as well. So we use shotgun metagenomic testing. So this is assessing the presence and absence of your good and your bad bacteria as well. So like Joe was saying, it's really important that you're on that bell curve, that you don't have really high levels or really low levels, and also that we look at good bacteria and we make sure that you have the right ones. Most of us actually don't have the right good bacteria in our oral microbiome, and we often actually have to acquire it from elsewhere. Talking about those virulent strains. So this is for your Porphyromonas gingivalis. So the test actually does look at all of those virulence factors that we spoke about. So all your gingipanes, your fimbriae, and your virulence factors as well. And you can see this patient, for example, had quite a few virulence factors elevated as well. Onto our AA. So we also are able to find that patient who has the JP2 clone. We're also able to find the hyperleukotoxic patient, the one who has those really aggressive strains of AA. Doesn't mean they have periodontal disease. It just means that the AA that they have in their mouth is at very high risk of causing them problems, so they have to be a little bit more careful. We also look at the whole microbiome, so we're able to actually balance your good bacteria versus your bad bacteria. And then there's so many other bacteria that we still don't understand, and we don't know much about it all. But actually what we've done is that at the end of the test report, you've got all the bacteria levels. And if you want to go and do a deep dive or you want to research something, I like check every test, like really into it, because, you know. And I had a patient who had really bad breath, and she she didn't have gum disease. She was like a bit inflamed. We didn't really know what was going on. She did the oral microbiome test, and then nothing kind of came up bad. Everything was kind of good. So I went to the back and I looked at all of the detected organisms, and she had really high levels of this random bacteria, and I started Googling it, and it's really high in dogs. And then I knew she had 4 dogs. So I was like, do you kiss your dog? And she was like, yeah, I kiss my dogs all the time. I love it, la, la, la. I was like, do your dogs have bad breath? She was like, yeah, my dogs actually all have gum disease. And something as simple as that, and you can actually start to tie that in. So now she's having fine, her treatment, her perio stuff, and her dogs are having not perio treatment, but you can get like perio pills, which actually reduce their plaque. And so the dogs are having it, and so is she. And so you can start to tie up all of those links together, and it's pretty cool stuff, if I may say so. Like I said, we assess how the body is responding to the bacteria, so we're looking at your base pair mutations. So all of these are screenshots of the test reports, so you can see that this patient had no variations detected, so this person's pretty good. And then we also give you your scores. We give like scores on decay, on inflammation, on bad breath, and on gum disease. So we pool all of the data that is collected. So we make sure that every patient or whoever is using it has a questionnaire. It has their medical history. It's got their dental history, their food habits, their sugar habits, everything. On top of their bacteria, their genetic mutations, everything, to then create and predict these risk scores. We've used the data from our own patients at our clinic to actually strengthen this algorithm and to actually see what's good and what's bad. So that's how we've kind of created that as well. And then we've also, this is what I thought was always lacking, was personalized treatment recommendations. So it's by no means that we're going to sit there and tell you what to do, but we can give you some recommendations and suggestions of what works. So for example, something like having a glass of green tea every day is very good for Fusobacterium nucleatum. Something as simple and easy as that. So we've worked with dentists, nutritionists, functional medicine practitioners to actually create those personalized treatment plans and to help your patients actually improve their oral health. So those types of things can be from nutrition, lifestyle changes, supplements, your oral hygiene products, and then we get clinician heavy as well. So these are what your patient will see. It will tell them, you should have some probiotics, your prebiotics. You've got really high levels of P. gingivalis, so actually have some propolis. So propolis is a raw form of honey, really, really effective against P. gingivalis. Very natural, very easy and cheap. Consume some Manuka honey regularly. Drink a cup of green tea. So it's quite simple, easy things that your patients can all actually do, and they've all been clinically proven to reduce those levels. I've also always put references. So if you don't believe me, you can click on the reference and then you can see if you still believe me. It's all on a client portal, so you can actually go and you can click and find which patient you're looking for. You can look at what's going on in there as well. And in terms of the financial benefit and what it looks like, so the test is £350 that's what we recommend for retail. I know people who are selling it up to 400, 450, whatever you like. Some people are doing it in packages for periodontal treatment. So if a patient's diagnosed with periodontal disease, they're like, okay, I need to know what bacteria is causing that. I need to know what genetic mutations you have. So you're going to have that, and it'll be a package with your full mouth debridement and your 3-month follow-up. So you can make it quite nice in a package like that. The cost for clinicians is £280. So you have that markup. What's really great about this test as well is that it actually really, if you want dental hygienists or dental therapists, or any of you here are, it really empowers you guys to start using the test as well. You can use it on every patient if you wanted to, and you can start to actually improve and personalize your treatment results as well. In my opinion, it takes 5 minutes, by the way, super quick and easy for money. But also, and sorry, I hate talking about money, but people do have practices here and run businesses. So it does also increase your case acceptance of periodontal disease. In my experience, I've never had a patient not accept periodontal disease when I show them their microbiome results, because they're sold. They don't have to be sold. They know that they have these mutations and all these bacteria. They will 100% go ahead with treatment. Increased acceptance of reduced recall rates as well. So there's already been quite a lot of studies and research in America to see that when you start doing oral microbiome testing and you show these patients and educate them on what's going on in their mouths, they're much more likely to come more regularly. And so actually these practices are making more money through their hygienists than often their dentists are anymore. So again, really helps with that. Increased loyalty from your patients. and also increased sale of sundries. So a lot of our recommendations, and you can change them, we can speak, if you guys are having lots of tests and you're like, you know what, I don't like your recommendations, I really like this toothpaste or whatever, then we can start to work and see how that can work for your particular practice if you wanted to. But what we always recommend is I like to do like a high range, medium range, and low range for your toothpaste, your toothbrushes, even your TP brushes, all of those types of things. So patients always have the options of it. But again, in my experience at our clinic, we have such a high amount from our sundries because patients see that and they're like, okay, cool. Also, you've got links on every single treatment recommendation, so they can just click it and buy whatever they want as well. So I'd say the advantages are you can actually diagnose disease quantitatively and precisely, in my opinion, for the first time. You can identify patients who may be resistant to periodontal treatment. And my final lecture this afternoon will be just case studies, just looking at how I've applied it to my patients, how I've picked up patients who have been resistant to normal periodontal treatment, how recommending one supplement has improved their periodontal treatment. You can identify patients who are at risk of oral diseases. So we should stop trying to treat disease in our patients and actually prevent them from having it in the first place as well. And also you can start to personalize your treatment and improve those outcomes as well. We also give antibiotic recommendations too. So if your patient has really high levels of anaerobic bacteria, then maybe we'll recommend metronidazole or whatever. So we help you actually decide on what antibiotic would be best for your patient's oral microbiome with the hope of actually less antibiotic resistance, and then also tracking of your treatment as well. So there are lots of people outside talking about it, and I think we're already sold out, but of the physical ones here. So we're taking all the orders, and they get shipped out to you within a couple of days as well. Another really cool thing about it is that if you buy the tests, some people are like, oh, I've never done this before, I don't know how many people are going to buy them. You can buy a bunch, they don't expire, nothing happens to them until someone spits into the cup, and then obviously the time ticking starts. So I'm just gonna again show you here how it actually works, and then I'll let you guys have your lunch.
Hi, my name is Dr. Victoria Sampson, and I'm the founder of THS Labs. Today, I'm going to walk you through how to do your oral microbiome test. So first, take all of the contents out of the packaging. Scan the QR code on the form and enter your sample barcode. Click Next. Fill in the required fields and click Register. Now it's time for sample collection. Place the funnel opening under your mouth and spit saliva into the funnel. Repeat until the saliva liquid, not the foam, reaches the fill line. Make sure you haven't eaten or drank anything for at least 30 minutes before you do your microbiome test. Once you've finished collecting your saliva, take the funnel out of the tube and close the tube with the cap, making sure that it is tightly secured. Shake the closed tube vigorously for about 10 times. Place the closed tube into the safety bag with the pad and ensure it is sealed. Place the safety bag with the sample into the return box. Insert the return box into the return envelope and seal it. Your results will be sent back 3 to 4 weeks after you've sent them to the lab. Once you've received your results, if you have any questions, check our FAQs or message us to speak to one of our clinicians to get more detailed insights into your results.
So if any of you guys have any questions, please let me know. Any questions?
Yes. If you change your gut microbiome, does that also change your oral microbiome?
So there has been, yes. So it's bi-directional. For sure, if you're improving your gut, it will improve the oral microbiome as well. But not what I've found a lot of patients is that they spend so much time on their gut and they have a beautiful gut microbiome, but not oral. So it does impact it, but I wouldn't say it's enough to completely change it. Yeah.
And artificial sugars, do they have an effect on reducing periodontal disease compared to people consuming normal sugars?
For periodontal disease?
Yeah.
No. So there's no kind of improvement or, no.
If they stop taking sugar and just take the artificial one?
Not for periodontal disease, no, not necessarily. For decay, yes. I mean, so if you were to use, when we say artificial sugars, more like your xylitol or your erythritol, then yes. Erythritol and xylitol are also naturally antibacterial, so there will be a benefit to the gums and periodontally. So what I also do recommend a lot of patients who have periodontal disease or dry mouth is that they chew chewing gum, which has some xylitol or erythritol in it, so it's naturally antibacterial. And you guys all have some lovely goodie bags over there, which has my mecca of my favorite products, and everyone. So all the companies have been really kind to contribute, and one of them is my favorite mints, which have erythritol and green tea extract in them.
But then it might stimulate a glucose spike, and then that might increase inflammation.
It's one mint. I don't think it's going to stimulate a glucose spike, no. And you're only meant to take up to 5 a day, so no, it wouldn't. No. Yep.
So with your workflow, I know it's quite different with different practices, but do you see the patient, they do the test, and do you get the patient back to go through it with them, or do they just look at the test and home by themselves?
So they can actually do it by themselves completely. So my workflow is usually like new patient consultation. They do their oral microbiome test. If I'll diagnose them with periodontal, if they have pocketing, for example, then we know that they need periodontal treatment. I'll always book them 4 weeks later because I want my microbiome results to be back. And before their appointment, they will have all of that sent over. During the appointment, we can talk it through. And then I also have like what I'm going to be using and how I'm, my own things from the oral microbiome results as well.
Okay. And they can buy those sundries at the practice?
Yeah, so you can buy, so this is obviously also we can be very flexible, and this is how it works for me, is that a lot of our patients, they travel and that, so we've put like links so they can just buy everything online, but you could also, I think it's easier if you have those products there and you make like a bag and you're like, this is what you need for your treatment, and make a package basically out of that.
Okay.
Can I just ask, following on from that, how often would you repeat the test? Just when they get issues after the first patient?
So you can, if you want to be like your health optimizer and absolutely amazing, once a year is great. If you're doing periodontal treatment and you want to actually check before and after, then 6 months. So you want to do your treatment, then you're going to recall them 3 months. Actually, sorry, not 6 months, 4 months. So you do a treatment, recall after 3 months, and then you do need to wait 2 to 3 weeks for everything to settle if you're doing a hygiene before you do it again. And that's another thing. If you're going to be doing an oral microbiome test, make sure you always do it before the hygiene, not after. Otherwise, you're going to get some crazy results. So, yeah. Yeah.
Done on any age of patient?
So at the moment, we recommend it for over the age of 18. Technically, you can do it earlier, but the research into children and their microbiomes is even less than that of adults, and there's not as much for, right now for oral microbiome. So we kind of understand that the child's oral microbiome fully kind of develops between around 11-ish, 12-ish. So I have had a patient or two who have been like, can I do the test because I want to look at the mutation side of things? That's always going to be the same. But the reason we haven't recommended it for less than 18 is that there can still be quite a lot of variation. But maybe down the line we will. So it's up to you really. But we might have a bit of variation with that. Yeah.
Does this test include the genetic and enzyme testing, or is that separate?
It does the genetic, not the enzyme. So the AMMP8, no.
Okay.
But it does all the genetics. So all of those base pair mutations I went through are all in this test. And all the virulence factors and all the bacteria I specifically went through are all included in this test as well.
On the enzymes, it's entirely separate.
It's a separate one because it's point of care. So you do it in the clinic then and there. So you would have to buy that separately, basically. Yeah. Try to incorporate it. It doesn't work.
Yeah, no, that's great. Regarding with sundries to stock, will they let us know there, the reps let us know there what sundries to buy?
So, no. Come to me. Because, so we have, some of the sundries have been recommended. Like I've basically put the exhibitors who I use, but they don't supply all of the products. So I can also, so for example, when you do your first test, you'll start to see what types of things we recommend. I mean, it's not copy and paste every time, but I could also just write you a list of like all the products, and then you can pick and choose and decide. Because like I said, also we always give like 3 options for each one so that you have the clinical idea of what you want to recommend to your patient more. Yeah. Anyways, yeah.
Despite the dietary interventions and things like that, with regards to things like periodontal disease, how would this change your treatment protocol?
If we have some dietary requirements?
No, I mean, just from the findings that you find, how would it change your treatment protocol? Say if you had the test and didn't have the test, what would be the difference in terms of how you would treat the patient based on what you find in the results?
So that's a good question. So if you, for example, here, for example, so yes, we can all recommend like vitamin D supplementation or, you know, like those type, we've kind of got those blanket recommendations. But then actually, for example, if you have really high levels of Fusobacterium nucleatum, then you would recommend green tea. If you have high levels of Porphyromonas gingivalis, then it's Manuka honey and propolis. If you have the TNF gene mutation, then actually something like, I can never pronounce it, resveratrol, is a really good supplement to actually reduce the TNF production. So we go deeper in terms of like how to reduce inflammation. One of the other risks that we look at, the risk assessments, is general inflammation. And so the reason we've done that is we're looking at the genetic mutations which are increasing your production of inflammatory markers. And then the supplement and nutrition is really aimed at reducing that inflammation, which you wouldn't really get if you didn't do the test, basically.
Instead of that being aside with the diet, is there anything you change in terms of the actual treatment that you would do?
Yes. Yes. So do you mean like...
Your periodontist, what would they do differently from a treatment perspective?
Okay, fine. So I'm really into doing like irrigation with certain mouthwashes. So we would recommend what mouthwashes you should irrigate with. So if it's very anaerobic bacteria, you want to oxidize those types of things, you'd use hydrogen peroxide, for example. Antibiotic prescriptions as well. Also, we're starting to look into other things like ozone therapy, lasers. So we even just give you recommendations so you can start looking into that. I think the most important bit is the irrigation, the antibiotics, and also the mouthwash that we would recommend that you give to your patient. So at the moment, most people are just using like Corsidol or, you know, and they're like, okay, use that and then you'll be fine. But actually, in some cases, hydrogen peroxide is better or, you know, CPC or all those types of things as well. No.
At what stage, is there like a specific stage on the BSB guideline you decide you might need a test regarding that? Where would you send up for that test?
For inflammatory markers? Like I said, it's difficult because the inflammatory markers that you'd see in the saliva could be from the rest of your body. And so that's why we didn't include it because it was a little bit too confusing. I wouldn't be able to give you like a mark in the BSB where you would start to recommend it. I would say if you have any patient with periodontal disease and you have that ability to check their inflammatory markers via their blood, then that's actually a really nice addition. And that's also where you can start integrating the medicine too. So you could do, like at our clinic, we do our vitamin D, and also we can look at inflammatory markers. So we can do a blood test on them at the same time and check.
Do you usually do it after your own test? Or?
At the same time. Doesn't make a difference. It's not going to change whether or not I do the oral microbiome test or not. But if I did do the oral microbiome test and the patient was super high on general inflammation, I might be more likely to refer either to a functional medicine practitioner or a doctor or to do a blood test to check their inflammatory markers. Thank you. All right, guys. So I think it's now lunchtime. If you guys have any questions, then you can come and speak to me. And yeah, this is the QR code if you want to buy your test. But also, obviously, if you guys want to discuss it with me, then please do.